Well, sir, are you there?
Sir, I'm just landing, sir.
No problem. No problem. No, 3 minutes
Okay,
I'll
sir.
start. No, 3 minutes I'll
Yes, sir.
start.
Yes, sir.
Professor,
Please, sir. Please,
Professor
sir.
Amit Gupta has joined. Professor Nishikant.
Yes, sir, Professor. Yes, sir.
Gujar
Good
has
evening,
joined.
everyone. Good evening, everyone. Good evening, sir.
Good evening, Dr. Kanagwel.
Sir, I'm just landing. We'll be joining in few seconds, sir. Maybe once I'm out of the flight.
No problem.
Please
No
start
problem,
the class
sir.
at 8 o'clock. Yes, sir.
Yes, sir. Professor Nishikant Gujar has joined from Kim. Welcome, sir.
Good evening, sir.
Welcome, sir.
Sir, good evening.
Good evening. I am from Coimbatore. Professor
Yes, sir.
Kanagwel and Professor Chetan Kantaria from yet to join. Today we have the 200th session, sir. 200th session of the PG clinics running.
Yeah, that's a landmark.
A landmark, sir.
And somehow I feel that amongst postgraduates, sessions have become quite popular across the length and breadth of the country.
Yes, sir. Yes, sir. Definitely, sir. And all are available in the YouTube also, sir. And faculties from all over India. So all the questions are there. Good evening, Jailal, sir.
Good evening, Srinivasan sir. Nice
Jayakana, sir. Good evening, sir.
long time.
Good evening.
Sir.
Amit Gupta sir is also there. And
Amit Gupta is there. Professor Nishikant Gujar from Vijaypura is there.
Sagai sir is there.
Sagai sir. Ajay Khanna sir is joining. Good evening, Ajay Khanna sir.
Good evening, sir.
Good evening, sir.
Good evening. Good evening.
Good evening, sir.
Hi, Dr. Amit.
Good evening, sir.
Good evening, Kanna, sir. Hello, sir. Good evening, senior faculty. Good evening.
You are rich.
He's in the...
Just landed, sir.
Just landed inside the flight.
Yes, sir.
Yes, sir. Yes, sir.
Okay.
Sir, you please start, sir. In fact, I just want to thank everyone. This is our 200th session. So thanks for all the faculty who have traveled. I think most of the faculty here have traveled and were available for the 200 sessions altogether, except 1 or 2 here and there. So I think we are reaching 5 lakh views in shortly, and we have crossed 4,90,000 views. And we have 14,200 members subscribed to our channel, sir. Thanks to all the faculty and the residents who made this possible.
Congrats, sir.
I request the faculty to conduct the proceedings, sir. Thank you. Congratulations to all of us, sir.
So with the permission of the faculty, we can start the 200th session of the PG clinics. PG clinics, it's a real great achievement. Thanks to our senior professors, Ajay Khanna, Jay Rajiv sir, Jailal sir. Previously we had, yes sir, it's full house. Rajiv sir has said it's a full house. We are very happy. So today we have 2 interesting cases. One is from Madurai Medical College and another one is from, which college, sir? I forgot. BJMC Ahmedabad. Obstructive Jaundice by Darwin and portal hypertension from Abhigyan Das. We have invited faculty, Professor Amit Gupta from AIMS Rishikesh. Professor Chetan Kantaria will be joining. He is from Chem Hospital, Mumbai. And Rishikant Gujar sir has already joined. He is from Alamin Medical College, Jaipur. We have our senior faculties, Professor Ajay Khanna sir, Professor Rajiv sir, Professor Jailal sir, Professor Shenoy sir is using today. Our other professors, Professor Karnaran sir, and others. With these few words, I request Dr. Darwin from Madurai Medical College, currently contributed by Dr. Saravanan and his HOD, Dr. Syed. You can start sharing by introduce yourself, your unit chief and your HOD. and start presenting. Okay. Faculties kindly take over, please. Rajiv
Yes,
sir was there.
Darwin, please start.
Rajiv sir
Okay,
was
sir.
there. Rajiv sir, are you there?
Raju sir has joined.
Yes, yes, I'm
Yes,
there. I'm
yes,
there.
yes, sir. Yes, sir. Yes, I good. Okay, start. Darwin, you can start.
Yes, sir. Good evening, sir. My name is Darwin. I am second year
Louder,
postgraduate.
Darwin,
And-
little louder.
Okay, sir. I am second year postgraduate from Department of General Surgery, Madurai Medical College. My unit chief and guide is Professor Dr. K. Saravanan, MS, and head of the department is Professor Dr. Syed Ibrahim, MS.
Darwin, no one sound venupa.
Okay, sir. Can I start, sir?
Yes, you're louder, please.
Okay. 34-year-old male patient, Goldsmith by occupation, residing in Madurai, came with chief complaints of yellowish discoloration of eyes for 1 month, passage of yellowish urine for 1 month. History of presenting illness. Patient was apparently normal before 1 month, and then he noticed yellowish discoloration of eyes and passage of yellowish urine, progressive in nature, no waxing and waning. No history of abdominal pain, no history of abdominal distension, no history of nausea, no history of vomiting, no history of hematemesis, no history of melena, history of loss of uptake present, history of loss of weight present. He lost 8 kilos. His previous weight was 60 kgs, and he lost 8 kilos in last 2 months. History of passage of pale colored stools present, history of itching all over the body present, history of sleep disturbance present, no history of fever. Past history, no history of previous surgery, no history of blood transfusion, no history of cholestatic or hepatotoxic blood intake. Medical history, patient is a known case of type 1 diabetes mellitus on insulin treatment for past 2 years. Is not a known case of hypertension, asthma, cardiac disease. Personal history, patient consumes alcohol 180 ml per day for the past 20 years. He is not a smoker. And family history nil significant, sir. Summary, a 34-year male patient who is a known alcoholic and diabetic presented with jaundice for 1 month with pruritus and passage of clay-colored stools with loss of uptake, loss of weight, and disturbed sleep pattern. Most probably a case of obstructive jaundice.
Go back to first slide. So you have mentioned that your patient is Goldsmith by occupation. Do you think that
Yes,
it
sir.
has something to do with the presentation?
He himself told that his work is hectic, and after his work, he used to drink alcohol. Nothing specific related to Goldsmith Johnson.
Okay, and in your complaint history, you didn't mention about the passage of clay-colored stool, but in the summary of the history, you are mentioning that patient is also passing clay-colored stool. And then the duration of symptoms is of 1 month duration, right? But when you told about the weight loss, you told about 2 months. Since last
Yes, sir,
2
the
months, patient has lost around 8 kg weight, right?
Yes,
So,
yes, sir.
so is that, I mean, the chronology?
Yes, sir.
Okay.
Darwin, you are saying
Initially,
2 months loss of weight, but your history, present history is for only 1 month.
Yes, sir. The patient just saw his weight 2 months before unintentionally, sir. So he told he was 60 kilos before 2 months, and now he's 52, sir.
And there is no history of abdominal pain ever?
No, sir. No history of abdominal pain, sir.
Okay, so what diagnosis is coming to your mind right now after looking at this history?
Obstructive jaundice, sir.
No, obstructive jaundice is not a diagnosis. What is the cause of obstructive jaundice? There is a malignant etiology, it seems.
He has a loss of weight and loss of uptake.
Okay, so
but-
what can be the possible cause as per this presentation? Painless,
Periodontary-
listen, painless, progressively increasing jaundice, right?
Sir.
And patient is having history of loss of appetite and loss of weight. So first
sir.
diagnosis should strike to your mind on clinical grounds is what? Here only. What should strike first into you?
Malignant etiology, sir. Malignancy may be due to periambulary CA or pancreatic carcinoma, sir.
So which pancreatic carcinoma? Carcinoma of the head of the pancreas.
Head of the pancreas.
So will you like to keep periambulary tumor as a first diagnosis or carcinoma head of the pancreas over periambulary tumor in this patient?
Head of pancreas, sir.
Okay. Yeah. Dr. Chetan Kantaria has joined.
Hello, Darwin.
Yes, sir.
Why you ask history of nausea, vomiting, hematemesis, and melena? What does this signify?
In pancreatitis,
Huh?
in pancreatic disorders, patient may have history of nausea, vomiting, and then
Hematemesis and melena is in pancreatic disease.
Why do you get
Yes, sir.
pancreatitis?
no, sir.
Suppose there is a patient with a jaundice, passage of yellow color urine and a yellow discoloration of the sclera. Which negative history we supposed to ask? Which negative history, or which point we supposed to exclude by the negative history? Not only pancreas, other etiological factors which are responsible for this.
Bile duct stones.
Other than bile duct stone, because there is no history of abdominal pain. How patient of CA stomach will present? What are the 5 classical ways of presentation of the CA stomach?
Vomiting, sir. Projectile vomiting, GO symptoms. Hematemesis, abdominal pain and distension.
So Darwin, the point here, what sir wants to drive home here is that wherever you are presenting a case of jaundice, please do not directly jump over the etiology from hepatopancreaticobiliary tract, right? There may be some other extra HPV causes of obstructive jaundice, which you need to rule out on history and on clinical examination. This is, sir, you want to extract from him? Dr. Jay?
And that the patient is within a 1 week, 1 month time, progressively he is losing weight. But you are very sure that he had no constitutional symptoms and he had no pain abdomen, he has no nausea. And what do you think that this 8 kg is lost in one month is due to that? His appetite, according to you, your appetite is good, no nausea, no vomiting, nothing, he is very comfortable.
The loss of appetite is there, sir.
Loss of appetite is there. Is
Yes,
it
sir.
loss of appetite? Early satiety?
Early satiety is there, sir.
Which is there? Both are different. What is loss of appetite? What is early satiety?
Early satiety is there. The patient couldn't eat his food what he was taken before, sir. Amount of
You are not mentioned that. You are talking only about an appetite. So the history-wise, because this is a very short 1 month duration, patient is having so much of difficulty. Definitely some other compelling difficulties for the patient must have. But you are concentrating purely on a pancreas, talking about waxing and waning. Within a 1 month duration, it is very difficult you will experience the waxing and waning. And you have also put a progressive of jaundice. And what was the early jaundice and what is the level jaundice is now? Is it a deepening of the jaundice or just jaundice is progressing slowly?
Progressing slowly, sir.
The benign condition also, the jaundice can be progressive. the chronic active hepatitis, the jaundice will be progressive. But if you are thinking in terms of malignant condition or a very serious condition, that way progressive deepening of the jaundice will be there. And what is happening here? What is your patient is having?
Deepening of jaundice. Because 1 month he told from.
How do you history wise know there is a deepening of jaundice?
He told initially the yellowish discoloration was mild and now it has severe. And
Dark
it's
yellow.
itching and
No.
itching and
You think dark yellow is a deepening of the jaundice? What will be the color of the jaundice and the eyes when you are having a deepening of the jaundice?
greenish yellow, sir.
So what was your present condition? You are not explaining all those things, just passing statements you are putting. Because if it's a long duration, you can understand, but it's short duration you are talking about, then you must be able to explain and how depth is that jaundice. That always gives a clue whether you are talking about more of a benign condition or a condition. You said this patient has 20 years alcohol history.
Yes, sir.
He's just 34.
Yes, sir.
That means he has started taking alcohol from 14 years.
Yes, sir.
You are sure? You are confirmed that?
Yes, sir. I confirmed it.
Okay.
Darwin,
Yes, sir.
hello. Directly
Yes.
don't jump over the diagnosis, because in negative history they are interested in your spectrum of differential diagnosis. How you are excluding other conditions, not directly toward the diagnosis.
Okay, sir.
Okay.
Dr. Darwin,
Yes, sir.
good evening.
Good evening, sir.
Symptoms, what are the symptoms which point to surgically obstructive jaundice, to surgical obstructive jaundice? What are the points in a history which definitely say that this could be a surgical obstructive jaundice?
He's having yellowish discoloration in eyes and passage of yellowish urine. That is jaundice.
That is jaundice. That's not
Clay-
characteristic of surgical jaundice.
He is passing clay-colored stool, sir. Clay-colored stool, sir.
Clear color stool is not very, it's not very common. In fact, it's quite rare to find. And if there's total obstruction, only then you'll get clay colored. And that's hardly there. There's never total obstruction so that you get clear colored stool.
Interchanging two words. In Darwin, sometimes you are saying pale colored stool. Sometimes you are saying clay colored stool in your history itself. And what do you mean by really that? Is both are same or both are different? Because one time you are saying it is a clay colored stool. Then you are saying sometimes it is the pale color stool, and your finger stall shows as a pale color, you said. And what is that you mean by that?
Sir, clay color stool suggests obstructive jaundice, sir.
No, what is mean by that? What is that clay color? What is the color of the clay you are seeing?
The absence of sterco in the stool, sir.
I'm not asking the etiology, but clinically, how will you ask the history to the patient?
Color of the stool, sir. That's
No, it differs from your food intake. It differs from the way you are passing. So it is only the recent change in the color of the stool. If the patient says one color and there is a change towards the pale, is more important than blankly saying clay. In our part of the country, clay is only a brownish color. Normal clay, what we are getting. That is not that we are meaning that. So there is a recent change in the color of the stool is what you have to make it out.
okay, sir.
So, Dr. Darwin, progressive jaundice with itching
Yes.
are
Yes,
the
sir.
two characteristics of surgical obstructive jaundice. Okay. Suppose we take your diagnosis as a periampullary carcinoma or a
Yes, sir.
carcinoma head of pancreas. In which periampullary carcinoma would you expect hematemesis and which type of periampullary carcinoma would you expect hematemesis and
Periampullary carcinoma. The duodenal part of periampullary
Excuse me?
carcinoma. Sir, can you hear, sir?
Dr. Darwin, could you be louder, please?
A duodenal part of periampullary carcinoma, he may get hematemesis.
duodenal malignancies. Okay. And what carcinoma head of pancreas, can they lead to hematemesis, Melina?
It may obstruct stomach or duodenum and can cause.
No, then you get vomiting. Why should you get hematemesis in Melina if there's obstruction? Yes, it can happen because when the head of pancreas infiltrates into the duodenum.
Sir?
When the CA head of pancreas infiltrates into the duodenum.
Yes, sir.
Right? Or you can get in ampullary type of carcinoma. Right? Okay. Then could you go to your next slide, please?
Okay.
How do you ask for waxing and waning of jaundice? You said no waxing and waning.
Sir, 2781 2581.
Patient is having just 1 month of history, sir.
What was the?
But I asked whether the color of the stools and color of his color of his urine and color of his eyes has changed. Any milder?
Would it? Suppose there's sloughing out of the tumor at the ampulla. Would the urine suddenly become clear?
No, sir. Within 1 month, it's very difficult to elicit, sir.
So what is a better way of finding out? This is not the right way. They will hardly tell you that my urine is cleared up or I've started getting colored stool. What happens is that the patient's appetite improves. Right? The jaundice will not yield. The decrease in jaundice is not appreciable.
Yes, sir.
Right? It's not appreciable much, but the patient's appetite improves. Okay, could we go to the next slide, please? Okay, itching. Why does the patient get itching?
In obstructive jaundice, on the bile pigments.
Yeah, what happens to them? Bile pigments or bile salts? Is it bile pigments or bile salts?
Bile salts, sir. Bile salts, sir.
So it's bile salts, yeah. What happens to them?
They through bloodstream they may go to the skin, sir. It causes itching.
So there are few theories. One is that the nerves endings get irritated, and second is that there's release of mast cells. They stimulate the mast cells to release. Okay. History of sleep disturbance. What do you mean by sleep disturbance? And why? Is it more? Is it less?
It is more, sir. Due to his itching, he couldn't sleep at night. That was his history, sir.
And suppose you were sleeping more, even in spite of itching then?
We have to think about hepatic causes of
Hepatic encephalopathy.
encephalopathy.
Okay, next slide, please.
Arvind, can you say what are the bile salts you know?
Okay, enumerate the bile salts, please.
Sir?
Enumerate the bile salts.
Bile acids?
Do you know them? Ursodeoxycholine, chinodeoxycholine. Have you heard of them? Have you heard of them?
Yes, sir.
Oh, you must know physiology also, no? That when functions of bile salts, if the bile salts are not, what are the complications you are going to get? So that's a basic in obstructive jaundice, and the physiological questions will be more.
Okay, Professor Gupta asked you about this guy being a goldsmith. So what's the significance of this? Is being a goldsmith?
There is a chance that accidental ingestion of gold, but it's not there. There's a chance for accidental ingestion of gold.
Oh, please. Please, cold is a noble.
Yeah.
It doesn't react with anything here. You ingest it, it just comes out. You heard of people fighting for cold, which is out of the rectum? No, they use chemicals to dissolve that thing, right? So
The
that could be a cause.
acceleration of
And what that would cause? That would cause
hepatotoxicity.
cholangiocarcinoma.
Yes, sir.
Yeah, Darwin, suppose this patient was giving history of chronic abdominal pain. Then what
Yes, sir.
pathology should have come to your mind that
Yes.
my patient is a case of this disease?
By stone disease, sir. Biliary stone disease.
No, it's a chronic
no,
abdominal
no.
pain,
Chronic
not
Biliary stone is an
occasional biliary
acute.
colics.
Chronic pancreatitis.
No, Darwin. This is related to his work, his profession. What is that element which causes anemia with chronic abdominal pain?
Lead, sir.
Yeah.
Yeah.
Right. Okay, next slide, please. Is not a smoker. Okay, alcohol past 20 years. Family history. What kind of family history do you ask for?
History of jaundice in his family from childhood. Anyone from childhood. Since childhood,
Everyone
is
gets a
having-
bout of jaundice in their life here, in India at least. Everyone. You must have also had a history of jaundice in your childhood, sometime in the past. Haven't you, Darwin?
Yes, sir.
Yeah, so
Hmm.
family history positive.
No, sir. Congenitally, anyone is having jaundice, sir. Or hemolytic anemias.
Okay. With say a head of pancreas.
No idea, sir.
Okay.
You said diabetes. How long he is diabetic?
20 years. Sorry. 2 years, sir.
2 years. You think it's a type 1 or type 2?
Type 1, sir. He's on insulin, sir.
Type 1 diabetes. So anything related to your disease and
Yes,
type
sir.
1?
He might be having chronic pancreatitis. He's a known alcoholic. He might be having chronic pancreatitis, which leads to
Darwin,
But,
loudly
but your
please.
history has no abdominal pain. No abdominal pain.
yes, sir.
And your first statement starts, patient is apparently normal before 1 month. The patient who is diabetic for 2 years, you mean to say your history that apparently normal fellow you are dealing with. So it is as far as possible, please avoid that statement in the first line. It's apparently normal before 1 month, and the past history you are coming and say 5 years he had this problem, that problem, hypertension. So you are supposed to say only what is the problem of the present history, what is that related to that present history.
Okay, sir.
And Darwin, why for diabetes mellitus he's on insulin only? Was he started on oral hypoglycemic agents, then switched over to insulin, or straight away he was started on insulin injection? In this era, I mean, he's a young patient and not overweight. So what was the pressing need to start insulin?
He was diagnosed by physician as type 1 diabetes, sir. He was started on oral hypoglycemic.
No,
medicine.
but
He was
you
not
have mentioned
responding.
here diabetes mellitus. So you cannot speak like type 1 diabetes, then it should have been type 2 diabetes, right? And if you join the dots, apart from abdominal pain, if this patient is also having abdominal pain, then the diagnosis might tilt towards chronic pancreatitis, alcohol induced, right?
Yes, sir.
And the patient's diabetes is also a feature of endocrine insufficiency. Maybe if you dig deeper and probe and ask him some more questions, maybe he may open up and tell you about some exocrine insufficiency as well, right?
Yes, sir.
And mind my words that chronic pancreatitis might be a harbinger for pancreatic carcinoma, pancreatic ductal adenocarcinoma.
Yes, sir.
Okay, let's go to your next slide, please. Next. Okay, so what do you think you're dealing with now? 34-year-old male, chronic alcohol consumption. Look, don't say alcoholic. Alcoholic means he's dependent.
Yes,
It's
sir.
chronic alcohol consumption.
Okay, sir.
With jaundice 1 month, with pruritus, takers 2. Okay, what do you think is you're dealing with?
Why do you call him as an alcoholic?
He was taking 180 ml per day for the past 20 years. So he must be a chronic alcoholic, sir.
No, there is no term called chronic alcoholic. And what is the definition of alcoholic? To call someone as alcoholic, and what are the criteria you must have?
3 to 4 drinks per day for men, or 20 drinks per week for men, and 2 to 3 drinks for women, and 8 per
They are
per week.
chronic habituated to alcohol. To term as alcoholic, they must have a physical dependence for the alcohol. They must have a blackout history. If they are not taking alcohol, they should have the withdrawal symptoms. And only the terminology of alcohol. Other things is called a habitat. This patient might have the alcoholic features because it's a chronic. He is taking alcohol for more than 20 years.
Yes.
So there's a difference between sorry.
Did you ask about the history of night blindness in this patient?
Specifically, I didn't ask, sir.
Can it happen? Can the night blindness happen in a patient with obstructive jaundice?
I don't know, sir.
What are the various vitamins which are not absorbed if it is patient with obstructive jaundice?
Vitamin K, A, D, E, K, sir. Fat soluble vitamins.
So the vitamin A is not getting absorbed. What can happen?
So night blindness might come.
Yeah, 5 to 10% of the cases, if you really ask, they give the history of the night blindness.
Okay.
Okay. What is the maximum bilirubin which can reach? Maximum total bilirubin which can reach?
More than 8.
Sorry?
No. How much is upper limit? No, sugar you can reach up to 500 milligram. Like this, bilirubin, how much it can get maximum?
No idea, sir.
Yeah, it doesn't go beyond 40 to 45 milligrams. Okay. Why it doesn't go beyond that? Because the cells, they start exfoliating especially from the jejunum. And that is why if the patient has got the pale color stool in the beginning and now it is become yellow, so this way both things, either the patient is improving or his obstruction is increasing, both ways. Okay, so it is not a very happy thing that the patient starts getting the yellow stool now, that the patient is improving. Majority of the time we think that it is becoming yellow, the patient is improving. So both things can happen. Okay?
Okay.
Yeah. Okay. You can go on the examination now.
Yes.
General examination. After getting consent with adequate privacy, patient is examined in a well-lit room. Patient is conscious, oriented to time, place, person. Is moderately built, afebrile, no pallor. Icterus present is greenish yellow in color. No cyanosis or clubbing. No lymphadenopathy, no pedal edema. Multiple scratch marks seen all over the body. His pulse rate was 68 per minute. Regular rhythm, normal volume. His blood pressure is 160 millimeter mercury in right arm sitting position. His oxygen saturation is 99% in room air.
Darwin, go back.
Inspection.
Go back to the previous slide. Can you really make a comment on pallor when patient is having jaundice, and that too when you are telling us it's a progressively increasing deep jaundice?
No, sir. Usually in jaundice patient,
No,
we
you cannot make a comment on pallor, even if patient is anemic, right? But
Yes,
categorically, you have written that there is no pallor, and pulse rate 68 per minute, in which vessel you have measured,
radial pulse, sir.
right side, left side.
Right side, sir.
So that also should have been mentioned here, right?
Okay.
And it's not only the rhythm and the volume, right?
Yes, sir.
So what type of pulse and what pulse you expect in a case of obstructive jaundice? Do you expect these patients to have bradycardia or tachycardia?
Bradycardia, sir.
Why?
Darwin, this is one question which we very often discuss in the PG clinic.
Sir.
Right? This question is straight from your first year physiology. So please try to find out the answer on your own, right? Next slide.
Your BP is only 160.
Yes, sir.
You are expecting a normal volume?
Maybe his baseline is 160. Sir.
Okay. Patient is dehydrated. Okay. Be
Darwin,
careful on that and check that. And
Darwin,
Yes, sir.
what is the commonest site of itching marks? Where will get the itching marks?
Chest and abdomen, sir. Chest and abdomen, sir.
Hello.
Is the flanks.
Sir, am I audible, sir?
Darwin?
yes, sorry.
Yes, sir.
Yeah, go on. It's the flanks. Okay, go on.
Okay.
Go on with it.
Inspection. Epigastric fullness seen with ill-defined borders, does not move with respiration. Umbilicus inverted midline. All quadrants move equally with respiration. Multiple scratch marks seen. No visible pulsations. No visible peristalsis. Flanks free. Renal angle free. Hernial orifices free. Left supraclavicular fossa free. External genitalia normal.
There are a lot of
Palpation.
marks. Darwin, in the picture, what you have shown, there is a lot of round marks are there. And the right flank region, there is a vertical scar-like things are there.
Yes, sir. That was due to his trivial injury which happened at his childhood, sir.
No, but you are not mentioning that. You are not
mentioning.
mentioning there is a scar. You are not mentioning there is a pigmentation colors are there. Only you are talking about multiple scratch marks.
Okay,
The
are those pigmentation important?
Yes, sir. But these pigmentations are due to after his itching history, sir. It happened.
No, it's got that blackish spots there.
No, it is very round. It is there. It cannot be like your scratch marks.
Those round black
don't-
marks.
After his itching, he developed some pustules and the scars happened. That was his history, sir.
Okay. Due to deposition, again, the salt by salt can get a deposition like that you will be able to see. It's not the typical nail scratch mark. It is a per se the deposition site that you are going to see that.
Yeah, Darwin, go on.
Palpation. Abdomen soft, no local rising temperature, no tenderness, guarding or rigidity. A lump of size 7.5 centimeter noted in the epigastrium. Firm in consistency, non-tender, smooth surface, well-defined borders, intra-abdominal, not moves with respiration and not pulsatile. Liver and spleen not palpable. Left supraclavicular fossa free. And external genitalia normal. Percussion, dullness noted over the lung. Auscultation, bowel sounds present. Rectal examination, inspection normal. Normal sphincter tone noted. No palpable mass, no rectal deposits, pale colored stools, stool staining noted. Systemic, other system examination, cardiovascular system, S1, S2 here, no murmurs. Respiratory system, normal vesicular breath sounds. Central nervous system, no focal neurological deficit.
Okay, what about his back? Darwin, have you examined his spine?
Yes, sir.
Darwin, why you are not making any note of prostate on rectal examination? Is it a, real patient or a simulated one?
Real patient.
Okay, so you must have done a digital rectal examination. What was the status of prostate? Were you able to feel the prostate lobes or not? 34-year-old male.
Prostate was not enlarged, sir. It was not palpable.
It was not palpable.
Yes, sir. It was not
What-
enlarged.
What do you mean by normal sphincter tone? Which sphincter you are talking?
Anal sphincter, sir.
No, which sphincter?
Yeah.
Anal has two
Anal
sphincters, no? Anal has two sphincters, internal sphincter, external sphincter. And which sphincter you are talking about? Normal sphincter tone.
External sphincter.
External sphincter is used for the squeeze pressure, not the resting tone. Unless you are asking the patient to squeeze your finger, then only you will be able to see that. The resting tone is by the internal sphincter. So both you have to. So each word which you are meaning, please understand that and do. When you are taking the sphincter tone and what is the importance of that. Internal sphincter for the resting tone.
Yeah, go on, Darwin, go on. Next slide. Don't have this embarrassing silence in between. Just go on.
Summary: a 34-year male patient is a known alcoholic and diabetic presented with jaundice for 1 month with pruritus and passage of pale color stools with loss of appetite and loss of weight. On examination, icterus present, multiple scratch marks present, epigastric lumbar size 7.7 into 5 centimeter, firm in consistency, smooth surface, well-defined borders, intra-abdominal. On rectal examination, pale color stools noted, sir.
No, you, Darwin, you are not, you said that it's a dull on percussion. Whether the dullness is continuing with the liver dullness?
No, sir.
No,
You are
not
who will
happening.
mention Darwin?
who will write all that things? You are having a epigastric mass, you are saying. So there is a differential diagnosis of that. So you need to differentiate and each. There's a passive statement you are making that means you are already know the diagnosis and you are putting it. Okay, go ahead.
Darwin,
Yes, sir.
what are the causes of epigastric masses?
Which does not move on respiration. Intra-abdominal epigastric mass which does not move on respiration. Let's come out with that, Darwin.
CA colon, sorry, epigastric. Duodenum.
It is the intra-abdominal mass. The question is intra-abdominal mass, which is not. You said the swelling is intra-abdominal.
Yes, sir.
Darwin, in per abdominal examination, you are not mentioned about the contour of abdomen. What is normal contour of abdomen?
Okay, Darwin.
Right.
Let's get your palpation. You have a lump in the epigastrium, which is 7 centimeters, quite large, right?
Yes.
Which is firm in
Mhm.
consistency, non-tender,
Mhm.
smooth margin surface, well-defined borders, intra-abdominal, not move with respiration and not pulsatile. Now, what are you thinking of?
It
What
is
could be your
history.
options?
Pseudocyst of pancreas might be an option.
Darwin, what is the shape of this lump? You have mentioned the size, but you have not mentioned about the shape and extent.
Oval shape.
So
sir.
this is confined only in the epigastrium.
Is your picture, you are showing the picture, mass you are written, is it confined to the epigastrium? Then we will ask next question, then boundaries of epigastrium.
It is not confined to epigastrium.
Look, Darwin. These are some very basic mistakes which you don't expect from a surgeon, right? You're going to be a surgeon. These are MBBS stuff, right? No one, you cannot expect to say these kind of things and get away, right? If you're saying that it's a pseudocyst and you're saying it's an intra-abdominal, I mean, very difficult. So you get your thoughts clear first, right? Obviously, the lump is extending into the umbilical region. So it's better to say it's in the upper middle quadrant, upper quadrant or epigastrium and the
Extending into umbilical region.
umbilical region, right?
And second, and you must be very careful whether saying you are committing it as intra-abdominal or not. Then you must explain what intra-abdominal only will not move with respiration.
Which is an epigastrium, right? So Darwin, I'll tell you, it's okay. These things happen, but what you have to learn is that this examination interpretation is very subjective, right? Maybe you're wrong. So if you have a diagnosis of say pseudocyst or say a head of pancreas, you should know what are the characteristics, right?
Yes.
And then recorrect when you examining and you think that you have made a mistake, you should correct it. You should go back and correct it. You get me?
Yes, sir.
Go on, please.
There is no ascites, no?
No ascites, sir.
It's not mentioned.
How did you know there is no ascites?
On percussion, no fluid thrill is there.
No, you are put only dullness water over the lump. You are not talking about percussion. Shifting dullness, you are not talking. You are thinking in terms of pancreas. You are thinking in terms of the swelling which is not moving. So you must look into the abdomen and possibility of even if that's not there, you must in the examination you must rule out there is no ascites.
Is ascites important in say
Yes, sir.
pseudocyst or pancreatitis or say head of pancreas? Is it important? It
Yes,
is,
sir.
isn't it? Like
Yes,
this, like the liver, which is size of liver, or the same way, ascites is important, right, Darwin?
Yes.
So Darwin,
are
you should
making a
mention free fluid in the abdomen on percussion, whether it is present or absent, right? So do not use word ascites on
yeah,
clinical
that's
examination.
right, sir. What sir is saying absolutely right. You should not use ascites, but you should say free fluid. And your
Okay.
history is only 1 month duration. With a 1 month duration, you want to make a diagnosis of pseudopancreatitis. What is the type of fluid collection you get within a 1 month period in the pancreas?
Acute peripancreatic fluid collection.
Yeah, that is because your history, everything you are confining only to 1 month duration within that.
Okay, go on, please. Next slide. Okay. Now, how will you manage this patient? What will you do?
Sir.
You've got this patient in your clinic. What will you do for him?
After examination, I will do ultrasound abdomen for this patient, sir.
Okay. What do you expect in the ultrasound?
Any intrahepatic biliary dilatation, any mass in the abdomen.
Right.
If it is any free fluid in the abdomen, any liver metastasis.
You talk for your case. You said there is a 7 into 5 centimeter mass in the abdomen.
So
But
the
you are
first
not going
thing
to.
what is the mass? What is the origin of that mass? Isn't it? Instead of looking for IHBR, the first thing I'm looking for is IHBR dilatation. I would rather look for what is the clump all about, isn't it?
Yes, sir.
Do
The
you
site
have
of
the
organ
ultrasound
of
report with you?
Sir?
Do you have the ultrasound report with you?
Ultrasound you are done?
Yes, sir. I have done, sir.
Just let's have the report.
Mild IHBR dilatation, CBD dilated measuring 11 millimeter, 7.4 plus 6.6 plus 7.6 centimeter, well-defined thick wall cystic lesion with fluid debris level seen in pancreatic body region compressing splenic vein, portal vein, and CBD. Volume 228 cc, wall thickness 2.3 millimeter. Multiple calcification noted in pancreatic duct.
Okay. So now what do you think it is? What's the diagnosis now?
Pseudocyst of pancreas.
Then how do you explain the jaundice? Progressive jaundice and clay-colored stool and itching and weight loss and loss of appetite.
If the patient has any features of portal hypertension?
No, sir.
What are the features you say? Portal hypertension, salient features?
In dilated veins.
Portal hypertension, what are the 3 cardinal features the patient will have?
Splenomegaly. Abdominal pain.
Splenomegaly, hematemesis, and ascites, or the fluid collection. Because there is both your splenic vein and portal vein are compressed.
Yes, sir.
There is a
Dr. Darwin,
possibility.
you have mentioned calcification in pancreatic duct. Do you have the size of pancreatic duct? Is it important to know?
Yes,
If
sir.
it is available. Because
Yes,
if they can see calcification in pancreatic duct, that means they can see the duct, right? So they must be able to measure the pancreatic duct size.
Calcification in pancreas or pancreatic duct?
Yes.
We say calculi in the pancreatic duct, calcification in the pancreas.
At least there should be some mention, not unremarkable or not seen. If it is dilated, is it important?
Yes, sir. It is important.
Darwin, what is the normal diameter of pancreatic duct, main pancreatic duct? Because when you know the normal only, then and then you can talk about abnormal thing.
Point 0.6 millimeters, sir.
0.3 millimeter. So 3 mm in head, 2 mm in body, and 1 mm in tail. Remember it like that. Head, body, and tail, right? 3 to 1. 3 mm, 2 mm, and 1 mm, right? So anything which is greater than 3 mm or 4 mm in the head needs to be investigated, right? It can be pathological.
Yes, sir.
The liver is 16.5 centimeter. But clinically, you are not saying the liver is not palpable.
So clinically, it was not palpable, sir.
So it has gone up. So then it will have compressed the diaphragm. Patient may have some other features of the chest discomfort. Because already the diameter is 16 centimeter, they are saying itself.
It is NLAS, but clinically I couldn't palpate, sir.
No, Darwin, you can't say clinical account. 16 centimeter liver, if you can't palpate, you'll have to learn to palpate the organs, right? You can't say I couldn't. You just can't get away with that, Darwin. No. Either your examinations were very cursory.
This is a
Okay.
bit tough case for you, but probably you have gone in a.
You are in third year, which year, Darwin?
No, all
Second
these
year.
are they are just entering into the final year, sir. So they will find it little difficult. Their experience
Okay.
less. So that is
Okay.
a one problem now we are facing here, because all the students who are going to present are from the just entering into the final year.
Okay. Okay.
And without having experience of watching these videos much.
That is
Yes.
Yeah.
No, you
Darwin,
should be.
That's fine.
One
That's
more
fine.
answer to what I asked you, that this young patient is on insulin injection. So the logical explanation for that is that this diabetes, which is secondary to chronic pancreatitis, is also called as pancreogenic diabetes or type C diabetes, which hardly is response to oral hypoglycemic agents, right? Although some
Yes, sir.
anecdotal reports say that they respond to sulfonylureas, but by and large they respond only to injectable insulin. Remember it.
because their insulin reserve will not be there. They are totally it is lost. The pancreatitis.
Okay. Darwin, then after ultrasound, what do you do?
I do routine blood investigations like complete blood count, renal function test with serum electrolytes, liver function test with coagulation profile.
Okay, go on. Okay,
Yes,
you've admitted the patient. So
Sir?
what treatment are you going to start? We'll come to that later on in this year. What treatment will you start? What are the principles of managing this patient?
First, we have to reduce this. We have to optimize the patient before surgery, sir.
So you want to
So,
first straight away reduce his jaundice.
Darwin, always remember when you are writing this value, please write with a unit. And what you are writing ALP 792, nobody knows and what it is that unit you are using. And SGOT, SCPT is not the terminologies which we are using now. And now when you are postgraduate, as we are presenting, you should not use those words. And both you are putting as a D bilirubin, direct bilirubin. So
second,
all your small presentation, you need to spend some time and see, correct it, put the units. Good, okay.
Darwin, we are not going to go and straight away reduce his jaundice. How will you reduce his jaundice?
sir, we have planned for ERCP for this patient, sir.
Straight away. Straight away. The patient's come to you, you've done the LFTs and ultrasound and send him for ERCP. Will you do something before that?
MRCP has already been done, sir. MRCP.
You have done MRCP
The
also.
patient is admitted in the ward. Any treatment will you give? What treatment will you give?
Vitamin K injection for 3 days, 10 ml per day for 3 days.
10 ml. 10 ml. How much?
10 milligrams.
10 ml of vitamin K.
10 milligrams.
Okay, 10 minutes.
Go back to the class. See that when you are giving injection, take that what the injection you are giving. Are you giving IV or IM? And if it is IV, what is the what drug? What can be given as an IV? So all that you must be very carefully watch, because all are important. Because now more drugs are coming in a different unit. So be careful. And how many dose you give? How much vitamin K you will give?
10 milligrams, sir.
No, how many days you will give?
3 days, sir. 3 days in 1 dose per day.
Your INR and bleeding time you are noted? LFT?
It was 1.6, sir.
Because you are going for the investigation, another ERCP and all. That bleeding time also you should note. Bleeding time in INR. Okay.
Okay, what else? Again, vitamin K, what else? Let's go quick. It's getting late.
His protein level. So ask this patient his hemoglobin levels, protein levels has to be.
What treatment will you give?
To reduce bilirubin, ERCP has to be done, sir.
Look, Darwin, the
Sir.
patient, you just admitted the patient in your ward. You'll push him out. Go, get your ERCP done. Will you start him on any medication? Will you hydrate the patient? Will you give him antibiotics?
Yes, sir. So I'll start with antibiotics. I need supportive treatments for itching.
What will you give for itching?
What is the supportive therapy you are going to give for itching? Treatment for itching?
Usually we give chlorpheniramine maleate, sir.
What do you give?
Chlorpheniramine maleate, CPM? No.
Okay, Darwin, look, I'm going to give you a piece of advice. I'm going to give you a piece of advice. If you don't know the answer, just say no.
Okay.
Right? Don't guess. Because that makes you look worse. Okay?
Okay.
Surgery, you got to be very honest and upfront. Say you don't know, we'll take it. First line of treatment is also deoxycholic acid. Right?
Yes, sir.
And you can give antihistamines.
Can give binding agents, cholesterol.
Right? And then you can give binding agents, cholestyramine. These are the stuff. Even rifampicin is used. Right? Okay. Anything else?
Dr. Darwin, can you correlate his bilirubin with sonography report of mild IHBR dilatation, 17.5 bilirubin? I think the CBD you mentioned is 11 mm, right? If I am not wrong. Do you think there is some discrepancy in the or mismatch in the sizes of IHBR and the level of bilirubin?
Yeah, there is total, even the collection is only in the body of the pancreas, and how
Yes.
it is going to come and compress, produce such a CBD is only 1.1 centimeter. Producing
The
a
pancreatic
jaundice
duct
of
is dilated. So what do you think? Dilated pancreatic duct, a collection compressing CBD as per the reports. If we believe it is true, what do you think is the possibility?
Pseudocyst compressing CBD, sir.
How do you explain dilated pancreatic duct, a chronic pancreatitis getting pseudocyst? Has he got any attack of pancreatitis?
No, he doesn't have history of any abdominal pain before, sir.
Okay.
what is the pancreatic CBD? The pancreas causing extrinsic compression of pancreatic CBD. What is that?
The part of CBD getting attached to pancreas.
So where you get a CBD in pancreas? So you have discussed with the radiologist?
No, sir.
Darwin, how
Yeah.
patient with the chronic pancreatitis will present?
He will present with pain, sir.
But in
Abdominal
your case,
pain.
there is no pain.
No pain, sir.
No history of
pain, no fever.
no past history also of pain.
No past history
Yes, sir.
also.
Yes, sir. No past history of pain, sir.
What is significance of fever in patients with stones?
Sorry, I couldn't get you, sir.
Huh?
Any fever history, constitutional symptoms was there?
No, sir.
What is Charcot triad?
Intermittent pain, intermittent jaundice, intermittent fever, sir.
And Renault Pentard?
With the hypotension and confusion.
Darwin, can you just define chronic pancreatitis? what is chronic pancreatitis?
Uh, the pancreatitis, which occurs more than 4 weeks, with collection of pancreatic juice, pancreatic enzymes within the pancreas, causing dilatation of pancreatic duct.
So Darwin, actually here lies the problem, right? So you have not got a very good understanding about the chronic pancreatitis. You do not know what actually it is, right? You are not able to define it correctly, right? And that's the reason that probably you are not looking into the things, right? So you need to, go through the topics very well again, and please read them very carefully. I think Dr. Jay, Dr. Jay Khanna, sir, will you like to give him a closing remark? As I think we have summed up with his 1 hour time, and we have to start with the next candidate's presentation. Dr. Jay Khanna, sir.
Yeah, he's joining, sir. He's coming. Khanna, sir? Yes, sir.
I think this case is quite a perplexing case, because we really do not know that what is that lump which you are feeling in this patient, you know, a lump which is there in the epigastric region with all the margins palpable, and the patient is having the bilirubin of almost about 17 milligrams %. So a lump in the body of the pancreas with a very high bilirubin. So it is very difficult to explain, but I think probably in this patient, the only way to explain about this jaundice which is there is probably the patient might be having either the CBD stone may be there, or because of the chronic pancreatitis, there is a stricture formation at that point. So that is probably the way you can explain in this patient. Now, as far as the treatment of this patient is concerned, why we treat the jaundice, the most important thing to treat the jaundice is to have a good quality of life, because the jaundice patient, they have got, because the itching which is there, that is the most distressing feature. Apart from all the complications which can occur in a jaundice patient, like the patient can be hepatorenal shutdown may be there, the patient with the cholangitis, all those things. But the most important, the quality of the life in the form of the itching which is there, and that's why the patient is not able to sleep because of that. So if you are going to treat a patient who is having a jaundice, you have to prepare that patient. You cannot just directly go for the ERCP and all those things, because any jaundice patient, if you are going to do any intervention, it has got all its complications. So you have to take care of the coagulopathy there, you have to take care of the infection, you have to take care of the cholangitis. So you have to give the patients the antibiotics, you have to have a very good hydration of that patient, you have to give the patient vitamin K, or the fresh frozen plasma has to be given. After you've corrected all these basic things, then only you can go for the ERCP, because ERCP has got its own complications. So before you land up in the ERCP, you have to correct all these things. And then you can relieve the patient from the jaundice by doing the ERCP in this patient. And probably in this patient, if you look overall, the patient has the brittle diabetes also. All these patients, the pancreatitis, what is called the brittle diabetes, that it is very difficult to control. Sometimes all of a sudden they will go into hypoglycemia, or they may have very high blood sugar may be there. So the sugar is very difficult to control in these patients. And then after all you have done the correction, these patients, they require the CT scan to finally look into that what is the problem there. You require the MRCP for these patients. And then based on that, you can start the patient with going for the ERCP to correct that. And further, you have to follow these patients to see that what is the progression of the pancreatitis is there.
So I think probably we are going to manage this patient in this way.
Sir, can I add one thing?
Yeah.
I think EUS will also be a good tool in an expert hand, particularly in
Yes.
young patient.
Yes.
Many times a small stone or stricture can be very well established by US.
Yes.
If there would not have been this collection, probably in a young alcoholic, chronic alcoholic male, one benign etiology of both the ducts dilated usually may present with gastric outlet obstruction. To keep in mind for PG students is groove pancreatitis or periduodenal paraduodenal pancreatitis,
Sure.
where patient does present with gastric outlet obstruction and both the dilated duct with jaundice. Just to keep in mind, not a common disease, but very rarely it can present.
Yeah. EUS has come in a big way now. EUS almost for all hepatopancreatic disease which is there. Any CBD problem which is there, any pancreatic problem is there. It has come in a big way to almost replace many of the surgical aspects which are there. Yeah. That's right. Yeah.
Thank you, sir.
Thank you, sir.
Especially when you are going for this pseudopancreatitis routine management also, you must be careful because already the splenic vein or under the compression, the possibility of developing a lot of aneurysms at
Yes.
that level is very high. So you need to be so extra cautious to see that the bleeding is or the angiogram is being done to see that assess the blood vessels are not much dilated. Otherwise, may end up in a lot of hemorrhagic problems.
Yeah. To check also for the left-sided portal hypertension in these patients.
Yes.
Yeah.
Thank you, sir. Dr. Darwin, do you have any doubts to clarify?
No, sir.
I hope all the faculty have given you the areas where you have to improve upon. So
Yes,
there
sir.
are always avenues to improve upon, and wish you go back. You have noted all these points and refresh your knowledge on this. Good
Arvind, you
luck
are
to you,
done
and
well. You are
wish you
done
could
well.
post us the developments.
Only thing you need to little more
Yes, sir.
confident, be smile, be happy about this, and all of us are here only to help you.
I
These are
think
the areas
probably
where you need
wrong
to-
selection at this level. In a second year student, this is a wrong selection of case. Probably you should have avoided this selection because it is confusing to
Awesome.
us also by the findings.
Point is taken, sir. Point is taken. Thank you, Dr. Darwin. Wish you good luck and wish we could hear the updates about this patient, about the final diagnosis and what was the treatment outcome. All right.
Oh,
Thank you very
sure,
much.
sir.
And kind regards to Professor Saravanan sir and Professor Ismail sir. Dr. Abhigyan Das, are you with us?
Yes, sir.
Dr. Darwin, you can stay with us for the discussion. Abhigyan is kindly contributed by Professor Modi sir from BJ Medical College. And he is here to talk about a case of splenomegaly. Abhigyan, please introduce yourself, your unit chief, your head of the department, and start your presentation.
Yes.
Good luck to you.
Good evening, sir. I am Abhigyan Das, a second-year general surgery resident of BJ Medical College, Ahmedabad. My chief of unit is Dr. Pankaj Modi, sir. And my-
One second, ma. One second. Dr. Darwin, you should unshare your PowerPoint.
Okay, sir.
Abhigyan, you can share your PPT now. Make it full screen. Go to the first slide and make it full screen.
Good evening, sir. I am Dr.
Good luck.
Abhigyan Das, second-year general surgery resident from BJ Medical College, Ahmedabad. My unit head is Dr. Pankaj Modi, sir, and my PG teacher is Dr. Maulik Mehta, sir. So I would like to start with my case. So, 48-year-old female patient, homemaker by profession of low socioeconomic status, residing in Madhya Pradesh, presented in OPD with complaint of lump on left side of the abdomen since last 15 years. There is also complaint of abdominal distension since last 1 year. History of presenting illness. Patient was relatively asymptomatic 15 years back, following which she developed a complaint of lump on left side of the abdomen since last 15 years, which was gradually progressive in size and reached to the current size and associated with abdominal discomfort. There is also complaint of abdominal distension since last 1 year, which is gradually progressive. Patient had history of one episode of jaundice 5 years back, for which she took medications which resolved within 2 weeks with oral medications. There is no history of fever, weight loss, itching, hematemesis, melanin, or bleeding per rectum. There is also no history of tapping of fluid from abdomen. Patient first consulted local doctor for this problem in Jabalpur 12 years back and took oral medications for 1 month. Upper GI scopy was done 2 times 5 years back at Bhopal, Madhya Pradesh. Patient was started on oral medications, which she discontinued after 1 month. There is also history of multiple blood transfusions in last 3 years for anemia. Past history. There is history of open tubal ligation done 8 years back. And there is history of branding mark over abdomen during childhood. And there is no past history of tuberculosis or any other chronic illness. Family history. Patient has 3 sisters and 1 brother, of which she is the youngest. There is no history of multiple blood transfusion or blood-related disorders in the siblings or in the parents. There is no history of any cancer-related deaths in the family. Personal history. Patient is married and has 3 children from normal vaginal deliveries. Last menstrual period was 15 days back and patient has regular menstrual cycles. Patient was delivered at home with no complications after birth. There is no known comorbidities. There is no history of addiction or any known drug allergies. Patient has adequate sleep and appetite with regular bowel and bladder habit. Case summary from history. It is a 48-year-old female patient from Madhya Pradesh presented with complaint of gradually progressive swelling on left side of the abdomen since last 15 years and abdominal distension since last 1 year. Patient had 1 episode of jaundice 5 years back, which resolved with oral medications. Patient also has history of upper GI scopy done 2 times 5 years back with multiple blood transfusions in last 3 years for anemia.
What is your conclusion by your history?
So,
what is your conclusion by your history?
So it is splenomegaly due to portal hypertension.
What are the point to say it is splenomegaly or portal hypertension?
So
by your history.
So from history, the patient complained of abdominal lump on left side of the abdomen since last 15 years. There is also
go to your first slide.
Yes.
Begin. I will like to draw your attention to the logic of taking history. You have started with presentation of history for since last 15 years, and in your history itself you have taken history before 5 years, before 3 years. So I think there should be some synchronization between the symptomatology of the recent onset. Why patient has come to you in OPD, for what symptoms? She hasn't come to you for lump in abdomen for 15 years. And it's in your history itself, you have taken history of 5 years back, some blood transfusion or tubal ligation. So I think you should not take a presenting symptom for last 15 years, just a suggestion, right?
Yes, sir.
Yeah, Abhigar, actually 48-year-old, please do not mention like male and female, just say 48-year-old lady and homemaker. Just no need to write like by profession, right?
Yes.
And then at times you are saying that it is the lump on the left side, and at times you are mentioning it is swelling in the abdomen, right? So there is a difference between the two. I hope you understand that.
Yes.
Right? And go back to the next slide. And again, see, actually, there is no order in the chronology, right? So the complaint which is occurring 1 year back, you are mentioning before the complaint which occurred 5 years back, right?
Yes.
Right. And the history of jaundice, actually, you should mention in the history of past illness, right?
Yes.
No need to mention it here.
Okay.
And why very categorically you are mentioning no history of tapping of free fluid from the abdomen? What do you want to rule out by mentioning this point here?
Sir, patient is complaining of abdominal distension, so I'm suspecting ascites for this patient. Sir, and there is no...
So the reason for abdominal distension can be ascites only.
No, sir. There can be several reasons, but with respect to the history of the patient since last 15 years, sir, I am suspecting there can be.
No, Abhigyan, look,
Yes.
because you think it's portal hypertension and you think it's ascites, this is a giveaway that you knew came across the diagnosis. No one takes this history. I mean, how does it help you? It just confounds your presentation, right?
Yes.
It's uncalled for, it's not required, and conveys no meaning, and doesn't help in any matter anyway,
Yes.
isn't it?
Yes.
So do away with it. Also, why have you come to the diagnosis of portal hypertension with just a lump abdomen for 15 years?
So there is.
Why?
So along with the lump of the on the left side of the abdomen since 15 years, patient also has history of upper GI scopy 5 years back, done 2 times, and there is also history of multiple transfusion of blood in last 3 years. So
why fight portal hypertension? Why can't it be thalassemia?
Yes, sir. Sir, so it can be both.
Why can't it be a bleeding disorder, an RBC disorder?
Yes, sir.
So
it can
look,
be both.
right. So look, the hallmark of portal hypertension is what?
So the ascites, splenomegaly, and sir, varies.
Any form of bleeding, hematemesis, yes. Right? So you don't have that.
Yes.
In your history. So please don't jump your horse. Okay?
Yes.
Thus, what is left-sided portal hypertension?
Sorry, sir. Your voice is breaking. Sir.
What is left-sided portal hypertension?
The left-sided portal hypertension is due to splenic vein thrombosis.
How patient will present?
So patient will usually present with splenomegaly, and so there can be anemia.
Anemia.
Professor Dalvi has raised his hand. Sir.
Yes, sir.
Professor Dalvi?
Yeah. I'm with you. That's not an issue.
Please, you've raised your hand, so that's why.
Yeah. See, my dear friend, when you present your history, there should not be anything that is put in the history backdrop when you have examined the patient. That's all that I want to say. That's where Dr. Sai is asking you all these questions. That history of abdominal tapping for some fluid because of distension, you cannot tell us in the history. That's all that I'm trying to tell you. So you have completed an examination and come to a conclusion, then decided that there should have been ascites. So I will ask this question, is it dangerous? Don't do it.
Yes.
Had there been history of tapping, you could have said. But no history of tapping is uncalled for.
Yes, sorry.
So go on, sir, please. Okay, go on.
And why you have asked history of itching in this patient?
Sir, due to sir, I was to rule out, sir, any cause of obstructive jaundice.
But is she jaundice right now?
So patient doesn't have any jaundice right now. So she previously had a history episode of jaundice 5 years back.
Okay, did you take history of varicose veins?
No, sir.
Then it's got nothing to do with it. 5 years back, she had jaundice. You're asking for itching just now.
Yes.
There is a dictum, Abhigyan. Error of omission is always better than error of commission. Remember this. Don't commit yourself unnecessarily. You are drawing yourself into the diverting subjects, right?
Yes.
But just a suggestion. Keep it in mind.
Yes.
Those which are relevant things, you definitely should ask.
What is sinistral portal hypertension?
So left-sided portal hypertension is also known as sinistral portal hypertension. So it is usually due to splenic vein thrombosis.
Right. Okay. Now tell how you can correlate the blood transfusion with the portal hypertension. Can the blood transfusion lead to portal hypertension?
So yes, sir.
How?
Sir, due to multiple blood transfusion, so there can be transmission of blood-borne virus like hepatitis B or C, which can cause, sir, any cirrhosis or any liver parenchymal disease, which may cause portal hypertension.
Good. Okay.
Yeah, next slide.
And why did you ask about the cancer-related death in your family history?
Sir,
what was the specific thing to ask in the cancer-related death in this patient?
Sir, in one of my differential diagnosis, sir, would be any kind of lymphoma, which might. So, sir, I asked for any kind of
For
cancer.
15 years?
Sir,
You said the history is for 15 years.
yes, sir.
So does that match your history of cancer-related death?
No, sir.
Okay, go ahead. What is the branding mark?
Sir, patient on the during childhood, sir, patient had sir branding. They in their village, they religiously get some kind of mark where the hot object is branded upon their abdomen as a kind of mark.
So can that lead to portal hypertension?
So no, sir.
Yes, it can. How it can lead to portal hypertension? You know, all those tattoo marking which are there, you
Yes,
can
sir.
transmit all the infection from there the same way the blood transfusion.
Yes.
Okay, so if you want to explain, you can explain by that.
Yes.
Okay.
Yes.
Yeah. Okay, go ahead.
And Abhigyan, please, in case summary, do not mention that history of upper GI scopy is there and multiple multiple transfusions are okay, but there is no need to mention about the history of upper GI scopy and CT scanning and everything, right?
Okay, sir.
You don't present case summary like that, right?
Yes.
So after, hearing till now, what your impression is all about, that what your patient is suffering from?
So my patient is suffering from splenomegaly. So it can be due to sir, hemolytic cause or sir due to portal hypertension.
So
What
why
is common cause of
splenomegaly?
splenomegaly?
Why splenomegaly? Why you are saying always there's a lump which is there in that area? It will be always spleen.
So it can also be a left renal swelling.
Yes. No, but you are directly saying it's a splenomegaly, isn't? No, there may be so
There is
many
no
lumps
urinary
can be there
symptoms.
in that area. You know, it may be adrenal may be there, it may be left kidney may be there, it may be the tail of the pancreas may be there, it may be chronic mass may be there. All those things may be there. Gist may be coming in that area.
And you have not taken any history for renal mass. Or for colonic mass. Look, Abhigyan, you have
Yes.
to when you have a lump in a certain area, you must think of what are the organs in that area and take history for each of those organs to rule them out. Isn't it?
Yes, sir.
Dr. Aved Dalvi has raised a hand again. Sir, please, any comment?
Yeah, I just want to ask him this question. This is a patient who has come to you with lump in left side upper abdomen. And there is progressive anemia requiring transfusions.
Yes.
These are two basic questions which I want to ask you. Is what comes to your mind first? This is a patient who has come to your OPD, says there are lumps since 15 years, and gives you history of two multiple transfusions. She's bleeding somewhere, correct?
Yes, sir.
Correct. What are the organs which can bleed from a lump in left hypochondrium that can give rise to anemia? It has to be chronic blood loss. You agree?
Yes, sir.
Yes. So name the organs which can bleed, giving rise to chronic anemia. That is the way history has to go.
Yes. So it can be a stomach. So due to any pathology in
Left
stomach.
hypochondrium lump.
Yes. Okay.
Don't get into the, you have been working for 1 year now, second year student. You must be examining patient.
Yes.
There is supposed to be a lump, which is the present complaint.
Yes.
You are examining the patient, but when you are talking to the patient, patient says, I've got a lump since 15 years and progressive anemia requiring transfusions. Which are the organs which can be responsible for such a thing?
So it can be, sir, colon at the splenic flexure.
Very good.
So there can be a mass at the splenic flexure which might cause occult bleeding.
Splenic flexure, stop there. Don't get into conversation with examiners. Second organ.
So it can be due to splenomegaly.
Correct. Because no colon is going to give you such a big mass that patient knew that it's for 15 years without symptoms, right?
Yes.
So colon is out. Spleen remains.
Yes.
What other things remain? Only spleen remains.
Yes. Yes.
Yeah. Now,
Abhigyan,
spleen
can it be a
related,
retroperitoneal mass? Can it be a retroperitoneal mass?
Yes, it can be.
fair enough. Let's not get into adrenals. Just want to ask you a question. Now you are focused on splenomegaly because it's a left LHC mass, spleen. So you walked into portal hypertension. My question to you is, once you know that this is likely to be related to spleen, how are you going to ask these questions to the patient?
Sir, I will ask for, sir, any history of hematemesis.
Other than hematemesis,
Sir,
commonest causes for splenomegaly.
sorry, sir.
Commonest cause for splenomegaly.
Sir, hemolytic anemia.
Which is the commonest cause of splenomegaly?
Thalassemia.
Do you know some infections?
Yes, sir. So it can be due to tropical splenomegaly due to the repeated malarial infections. So other infectious causes can be, sir, due to Kala-Jar, so due to disseminated tuberculosis, so due to infectious mononucleosis virus, sir, in cases of malaria, and sir, it can be, sir, due to any kind of HIV related HIV in cases, it can be splenomegaly.
Patient is having left-sided swelling from last 15 years.
Yes.
What is the cause for this? Commonest cause?
Sir, tropical splenomegaly, sir.
What does it mean?
Sir,
in tropical splenomegaly?
Sir, in tropical splenomegaly, sir, the patient presents with splenomegaly, and so there is usually anemia with that. So in our Indian subcontinent, due to repeated exposure to malarial antigens, so there can be, so it can cause tropical splenomegaly syndrome.
But you have not mentioned anywhere in the presentation.
Yes.
Okay, proceed.
So general examination. I have examined the patient in a well-lit room with proper exposure and due consent. Patient is conscious, alert, oriented to time, place, and person. Patient is well built and well nourished. Pallor and bilateral lower limb beating edema is present. There is no jaundice, clubbing, cyanosis, or generalized lymphadenopathy. Temperature is normal, pulse rate is 80 per minute, regular, and euvolemic as measured in right radial artery. Blood pressure is 110 by 70 millimeters of mercury in right brachial artery. Respiration is regular with respiratory rate of 16 per minute. There is no evidence of stigmata of chronic liver disease. Should I proceed with examination of abdomen?
Go back to the previous slide. Previous. So when you are mentioning about respiration is regular with respiratory rate, so here you should always mention about the type of respiration, whether it is thoracic-abdominal or abdominothoracic, right?
Yes.
And please correct the spelling of minute, 16 per minute, right? And you should mention about the vitals first, right? Rather than telling about the pallor and pitting edema in lower limbs, etc. and etc. Right?
Yes.
So vitals you should mention first, right? And temperature is normal means what type of have you measured the temperature by thermometer, or you should mention it patient is febrile on touch, right?
Yes.
And what type of no, you mentioned in one line no evidence of stigmata of CLD. So what stigmata you will like to see on
Sir,
general physical examination in this patient to rule out CLD?
So I would look for, sir, spider nevi. Sir, there in the hands we can look for leukonychia and palmar erythema. Dupuytren's contracture might be present. Sir, in case of males, we can look for gynecomastia or testicular atrophy. Sir, there can also be loss of hair and libido in case of males.
Any other, you will look for Dupuytren's contracture.
Yes, sir. So in the hand.
And flapping tremors.
Yes, asterix is.
Right. Okay. Next slide. Next slide, please.
Examination of abdomen. On inspection, abdomen is distended with flank fullness and centrally placed inverted umbilicus. Fullness is also present over the left hypochondrium. All quadrants of the abdomen move equally with respiration. There are no dilated veins seen over the abdomen. Two hypertrophic scars are present over the left half of the abdomen of approximately the size of 13 centimeter into 6 centimeter and 6 centimeter into 4 centimeter. Lower midline scar of previous surgery is present. There is no visible pulsation or peristalsis over the abdomen. So on palpation.
Why you are saying hypertrophic scars? Go back. Should you say that there is two hypertrophic scar? Because hypertrophic.
Meaning of hypertrophic.
So
that's a defined entity, right? And that's not hypertrophic scar which you are showing here in the figure.
Yes. So there is the. Yes.
Yeah, Dr. Dalvi has raised hand again. Sir, please make a comment.
Dr. Das, define a hypertrophic scar.
So
it's a basic question.
So it is due to increased collagen tissue production. So in the place of a previous scar.
See, you are
asking
listening to you. I've been listening to you. You're talking only theory. This is a clinical examination. So
Yes.
How does hypertrophic scar look to you? And when you decide that this is hypertrophic scar, don't talk about collagen.
Yes. So clinically, sir, in the place of a pre-existing scar mark, the hypertrophic scar is usually elevated and remains within the boundaries of the previous scar mark. It doesn't extend beyond the boundaries of the previous scar mark.
So when does it alert you that this is not hypertrophic scar, but maybe a malignancy?
Is there a time period?
The moment I take you away from the discussion, you are going to be in trouble.
Yes.
So tell me, when will you suspect that this is not a hypertrophic scar, not a keloid, but maybe a malignancy?
It might be associated with the sudden pain in the swelling.
Pain in squamous cell carcinoma, do you get pain?
No, sir.
So you say, I don't know, let's go on. Let the other examiners take over.
Abhigyan, is
No,
there
no,
a
sir.
time frame for you to distinguish between hypertrophic scar and a keloid?
Sir, I don't know, sir.
Okay, it's 6 months.
Yes.
So now describe the scar. It's obvious it's a hypopigmented scar.
Yes. So it is a sir, hyperpigmented scar with patches of hypopigmentation in between.
Yeah, or you say variegated, it's a hypo or hyper variegated scar,
Yes.
isn't it?
Yes.
Not of much significance because they use this kind of things to alleviate the pain, right?
Yes.
Yeah, go on, please.
So with the next slide.
Yep.
So on palpation, inspectory findings are confirmed by palpation. Temperature of the abdomen is normal over all quadrants. Tenderness is
Look, Abhigyan,
yes.
inspectory findings are confirmed by palpation is a age-old, much done away with statement. Either you say what you've seen on palpation or you don't. Don't say, go, you're asking the examiner to go have a look at what I've done in inspection and let's proceed. That's wrong. Go on.
So temperature of the abdomen is normal over all quadrants. Tenderness is absent. Spleen is firm, non-tender.
Hang on, why do you take temperature of the abdomen in all quadrants? Is the patient febrile?
So not at present.
Then why?
So there may be a local rise of temperature if.
Okay, in what condition will get local rise of temperature with a normal colored abdomen? Is there an abscess anywhere?
No, sir.
Is there any signs of inflammation?
No signs of inflammation.
Then why? Go on.
Yes. So spleen is firm, non-tender, extending 20 centimeter below the left costal margin from the left hypochondrium to the umbilicus, with smooth surface and regular sharp edge moving with respiration. It is not crossing the midline. A distinct notch can be felt on its anterior edge. Fingers cannot be insinuated below the left costal margin. So liver is not palpable. Hernial sites are normal.
Abhigyan, go to your inspection slide.
Yes.
So it looks like you have not examined the back of the patient, right? For you, anterior abdominal wall is only the abdomen, right? In such an important case. And similarly, go to the palpation. It doesn't appear that you have palpated the back, right? You have not looked for the spine. You have not mentioned about the spinal tenderness, right? So very important.
The renal angle.
Miss, yes,
Renal
renal
angle.
angles.
No.
Guys, so that's a very big mistake you have committed, right? In a long case, and that too in an abdominal lump, you shouldn't commit it, right? And you said that the notch is felt on the anterior edge. Should you call it as anterior edge or anterior border?
So borders.
Okay, next slide.
On percussion, dull note is present over the swelling. So liver span is 13 centimeter along the mid-clavicular line. Shifting dullness is present with absent fluid thread. Horseshoe dullness is also present. On auscultation, yes.
Hang on. What is this horseshoe dullness? What is this horseshoe dullness?
Sir, on percussing from away from the umbilicus on all sides, so there is a dullness present, which is in the shape of a horseshoe.
So in which condition will you find that?
So we can find that in ascites. With
Why is that is? What about ovarian tumors? What is the typical thing there then?
So I don't know.
I mean, why have you mentioned this? I can't understand. Is it to show that you know something more? What are you trying to tell us? Horseshoe dullness is present. What are you trying to tell us?
So I see.
Okay, what happens in an ovarian tumor? How is the dullness?
Dr. Das, I'm just coming in here.
Okay.
What is a horseshoe?
So it is now.
When you say it is horseshoe, you should know what is horseshoe. Tell me what is horseshoe. Simple question.
So it is in a shape of a inverted U, sir.
Yeah. Why is it put on a horse? So when you, my suggestion is only one. When you utter some words, you have to know the meaning of the words. Okay? Go ahead. You should have said simply, percussion reveals dullness in the flanks and in the pelvis. When you say horseshoe, these sort of questions can come up. Okay?
Yes.
Thank you.
So on auscultation, peristalsis is known. Perectal examination is normal. Cardiovascular and respiratory system examination is also known.
So what findings can you elicit in this lady on digital rectal examination?
So
what do you expect? Yeah, on rectal examination, what do you expect? What findings you can get in this case?
So rectal
In
examination.
case of portal hypertension.
Yes,
Keep
sir.
in mind this portal hypertension.
Sir, on rectal examination, on proctoscopy, I expect to find hemorrhoids, internal hemorrhoids in this patient.
Yes, that on proctoscopy you can find. I'm asking on digital rectal examination. What do you expect to get? You yourself are mentioning ascites or fluid in the abdomen, right? Many
Yes.
times you may not elicit the typical signs which you are mentioning on the percussion, that is shifting dullness and the horseshoe dullness, what you mentioned, right? But many times you may be able to appreciate or elicit free fluid in the pouch of Douglas and the bogginess, which you can elicit on digital rectal examination, right?
I think I'll simplify it for him. Patient with gross ascites, when you put your finger in the rectum, what should be your findings? Am I correct, Dr. Gupta?
Yes, sir.
Yeah.
Yes, sir. So we can also feel fluid in the pouch of Douglas.
How? How is it different from a normal PR examination? I'm just asking Dr. Gupta's question, making it simple for you. Correct, Dr. Gupta?
Yes, sir. Absolutely.
Sir, I don't know. Sir.
Thank you.
So
Gupta, you can go ahead.
Yeah, Abhigan, just can you, with this kind of case summary, what diagnosis will you like to give here? What is your provisional diagnosis?
my provisional diagnosis is splenomegaly with ascites due to portal hypertension in a 48-year-old lady.
Did you check for the liver size here?
Yes, sir.
Liver is not palpable.
So liver is not palpable, and sir, on percussion, liver span is 13 centimeters along the midclavicular line.
But you are not written anywhere, is it? Liver span. How much is the liver span here?
Yes, sir.
Is it important or not?
Yes, sir. It is. Sir, liver span is important because, sir, in there might be.
Did you check for the prominent veins over the abdominal wall here?
Yes, sir. No, there were no dilated veins over the abdomen.
In which position did you examine that?
So in supine positions.
No, if you really want to see, you have to examine the patient in the standing position for the abdominal wall veins. And where you will examine the veins in a suspected case of portal hypertension?
So I will below the umbilicus. So I will check for the veins around the umbilicus and mostly below the umbilicus.
So why below the umbilicus?
Why below the umbilicus?
So in that case, if veins are prominent, we will have to differentiate the flow of direction of flow of the veins.
Okay. So what you want to differentiate?
So differentiate between any kind of IVC obstruction or caput medusae due to portal hypertension.
Okay. And in the case of IVC obstruction, where else you can get the veins which may not be there in the portal hypertension? You see the back of the patient, okay? If you find the prominent veins in the back of the patient, then they go more in favor of the IVC obstruction.
Yes.
And how do you differentiate whether there are rectal varices are there or the hemorrhoids are there? You know, there can be rectal varices.
Yes. Sir.
In the patient suspected of portal hypertension.
Yes.
So how do you differentiate whether they are the hemorrhoids or they are the rectal varices?
Sir, I don't know. Sir.
Let me come in here.
Hemorrhoids, they are venous in origin or arterial in origin?
Sorry, sir.
Hemorrhoids are arterial in origin.
Question. Differentiate anastomosis, anatomical between superior rectal, inferior, and middle rectal vessel. That is the question he's asking you. If you know the answer, give it. Otherwise, say don't know.
Sir, don't know. Sir.
Das, what are the sites for porta systemic anastomosis?
So it can be in the it can be around the bare area of liver. So there can be site of anastomosis. So in there is paraesophageal area, there can be anastomosis within the azygos vein and the left gastric vein. In the rectum, there can be portosystemic connection between the inferior rectal vein and connection.
Is the rectal varices, is it a common condition?
So, no, sir.
It is very, very rare. So cirrhosis, the portal hypertension, having a rectal varices is rare. Because hemorrhoid is entirely a different concept. Rectal varices is a different concept. We don't normally get it there. Normally, when IVC is obstructed, what is the vein which connects IVC with the SVC? Suppose you get an IVC obstructed.
Yes.
So how the blood goes to the heart?
So, as I was
very good, very good. Esophagus vein is the main function of esophagus is only connect. How the esophagus veins are formed?
So there is a accessory esophagus vein. And
that is on the left side,
yes.
right side, left side. You know. So how the accessory esophagus is formed? Okay, so the superior rectal vein and the subcostal vein joins, then all other vein joins to the esophagus vein. So they mainly they do. This is a structure. What? Which vein you see when in the abdomen?
In the abdomen, sir, we look for the so in sorry, can you sir repeat your
question? Abdomen, you look for which vein?
So IVC.
No, IVC obstructed. So what vein will be dilated?
So azygos vein and
azygos you can't see, right? It is in the inside of the abdomen, in the anterior abdominal wall. Lateral thoracic veins. So how will you differentiate vein whether it's IVC obstruction or common iliac vein is obstructed? So when you see the abdomen, both the side, lateral thoracic veins on seen on both the side, that always indicate an IVC obstruction. If there is a one side, that says only the lower level. It is not the IVC is obstructed, common iliac vein is obstructed.
Yes.
Okay, the difference between the rectal varices and the hemorrhoids, if you see when you do the proctoscopy, the hemorrhoids, they look more pinkish, while rectal varices look more bluish. Okay, and when you put the proctoscope inside, the hemorrhoids will bulge inside the lumen of the proctoscope, while the rectal varices will compress by that. So that is the way you can differentiate between the rectal varices and the hemorrhoids. Okay. Right.
Case summary. 48-year-old female patient, 48-year-old lady from Madhya Pradesh, presented with complaint of gradually progressive abdominal lump since last 15 years and abdominal distension since last 1 year. Patient had one episode of jaundice 5 years back, which resolved with medications. Patient also had history of multiple blood transfusion in the last 3 years. On general examination, pallor and bilateral lower limb peating edema is present. On abdominal examination, a firm non-tender spleen with smooth and regular sharp border was felt extending 20 centimeters below the left costal margin from the left hypochondrium to the umbilicus and not crossing the midline. Shifting dullness is present with normal liver span.
Abhigyan,
Yes.
your case summary should be short and to the point, with positive points to your diagnosis and some. You can't say 2 centimeters below there and 5 centimeters here and there, all that kind of thing. It doesn't matter. Just say that it's spleen, which is enlarged. Okay?
Yes.
So what do you think
Again,
you're dealing with?
Just tell me one thing that what is the normal pressure in the portal system, portal vein, and when you say that patient is having portal hypertension, and what are the various methods in your hands you can deploy to measure portal pressure? So you got it. You got 3 questions.
Yes. So
Yeah.
portal hypertension is defined when the hepatic venous pressure gradient is greater than equal to 10 millimeters of mercury. So we measure.
It's in the millimeter of mercury, or you measure in the centimeter of water. You are right what you said the value. When normally salt can be also measured in the centimeter of water. How will you convert the centimeter of water to millimeter of mercury? You have to multiply by 1.5.
Yes. So normal pressure is within 1 to 5 millimeters of mercury, and so we usually measure it by cannulating the hepatic vein. We use we cannulate the hepatic vein and inflate the balloon, and we measure the hepatic waist hepatic venous pressure, and we deflate the balloon and measure the pressure, and it is venous free venous pressure, free intrahepatic venous pressure. And we subtract waist hepatic venous pressure from free hepatic venous pressure, and we get the hepatic venous pressure gradient. And so if it is greater than equal to 10 millimeters of mercury, we call it portal hypertension.
When will you expect the bleeding?
So we expect the bleeding when it is greater than 12 millimeters of mercury.
Good.
What is your diagnosis in this patient?
So my provisional diagnosis is splenomegaly with ascites due to portal hypertension in a 48-year-old lady. And so my differential diagnosis is tropical splenomegaly and splenomegaly due to hemolytic anemia.
So how do you explain the ascites?
Yes. It is not explained by my differential diagnosis. It is not supporting my differential diagnosis.
Why you are not coming out with the diagnosis of portal hypertension in this patient?
So due to there is ascites and there is splenomegaly in this patient. So which are 2 of the cardinal features of portal hypertension.
Dr. Dalvi wants to say something. Sir?
I'm just coming here to this boy So this is a patient who has come to you with 15 years of organomegaly. I'm not even calling it splenomegaly. Let's assume it's splenomegaly and persistent fall in hemoglobin without evidence of bleed. Now, where are your investigations leading you? I can't
He has
hear
not
you.
investigated, sir. He has not investigated. He is just.
I know. I don't want to point fingers to anybody.
Right.
How would you go about investigating this patient?
Yes.
50 years of splenomegaly, no evidence of bleed, falling hemoglobin. How have you come to the diagnosis of whatever you have come to a diagnosis? Let me make it more simpler. Whom would you refer this patient to help you in deciding whether to do splenectomy or no?
Hypersplenism.
Sir, I would like to take opinion of a gastroenterologist for this case. So I would like to.
How would you? How this person would help you?
Gastroenterologist, so how they are going to help you?
So I like to do, sir, upper GI scopy for this patient.
That is all. I think
why do you see the patient?
5 times the patient has been undergone upper GI endoscopy.
Yes. So to look for any kind of varices or any changes of.
Any other test you can do to rule out this, nothing to do with the surgical hypersplenism or any other features, why there is anemia other than bleeding.
Yes.
Abhigyan, can you define what is hypersplenism?
Yes, hypersplenism is a clinical syndrome characterized by splenomegaly. There is cytopenia. So there is normal or proliferative bone marrow. And sir, it is usually blood pressure is improved after splenectomy.
So can you keep this as one of the differential diagnoses, or can you keep it as a provisional diagnosis?
Because you don't have any history of bleeding, but there is anemia.
Yes, sir.
And spleen is enlarged. So that
Yes.
fits into that more.
Yes.
But what made you to think it is a portal hypertension?
Sir, there is ascites along with splenomegaly.
But it could be due to hypoproteinemia.
Yes. It can be.
Patient is
I'll ask you another question. When do you expect ascites in a patient of splenomegaly who is asymptomatic? What is happening to the liver?
So, due to intrahepatic pressure and so due to splanchnic vasodilatation, so there can be.
Can you make it more simple?
So there is increased blood flow into the.
Can you say cirrhosis?
Yes, sir. Sir, yes.
Yeah. What is cirrhosis? Define.
The cirrhosis is defined as fibro. There is fibrotic changes which lead to change in the ecotexture of the liver.
How does it affect the circulation?
So it increases the pressure in the sinusoids of the liver, which increases the pressure in the veins of the liver.
Which vein?
So hepatic veins.
Is it always fibrosis or it should be renal?
Now I'm forced to ask you a question.
Yes.
What is a basic hepatic structure?
So there is portal vein which is bringing the blood flow to the liver.
Structure.
Sir is asking structure.
The basic structure is a portal trad.
Yes. So what is the central thing that happens?
So there is.
That's the problem. I know you don't know, and we are getting deep into it. I don't want to get into deep of this. Let's look at diagnosis. You got a patient with splenomegaly with ascites. Whenever a patient with splenomegaly ascites comes into picture, what is to you happens about the liver?
Sir, we can suspect, sir, liver parenchymal disease in this patient.
Correct, correct. Absolutely fine. How are you going to treat this patient? Ajay sir, please take over.
Yes.
You know, whenever you are giving a diagnosis of portal hypertension, you have to always tell us that which type of the portal hypertension. Are you thinking of the EHPVO,
Yes.
or it is a hepatocellular variety, or it's a post-hepatic variety? So how will you clinically differentiate between these three? Is it a case of extrahepatic portal venous obstruction? What are the two common for the liver?
Sorry, sir.
What are the two common diseases for the liver, for the hepatocellular?
Yes. Sir,
What are the two common ones here?
for cirrhosis of liver,
One is cirrhosis, another is
there is non-cirrhotic portal fibrosis.
NCPF, and a non-cirrhotic portal fibrosis. And then it's the post-hepatic variety or the Budd-Chiari syndrome, which is there.
Yes.
Okay, so you have to give in here that are you dealing with a case of EHPVO, or is it a cirrhosis of the liver, or is the NCPF, or it is the Budd-Chiari syndrome?
Yes.
So out of these four, where this patient fits?
So it fits. So according to me, sir, my provisional diagnosis would be, sir, due to non-cirrhotic portal fibrosis.
Why you say non-cirrhotic portal fibrosis? Agreed.
Yes. So the patient lies in patient is 48-year-old female patient.
Yes.
What is the BMI for this patient?
BMI, sir, are not calculated.
Is there any connection with BMI and
So I don't.
it is most of the time it is a metabolic disorder, no? So it is very common the people who have the BMI is more, metabolic disease is there.
So this is a 48-year-old female patient. So there is history of anemia and so splenomegaly. There is history of anemia and splenomegaly, and there is also ascites. There is no history of hematemesis. So on examination, sir, there is a palpable huge enlarged spleen, and so liver span is normal.
So the most important, the liver span,
Yes.
which will decide about all those things. Here, the liver functions are relatively normal.
Normal, sir.
In the sense the patient does not have the jaundice, the patient does not have any coagulopathy, the patient, so all those things are relative, but the patient has got the ascites. Okay, so that is why you will first keep in this patient the probably a case of the NCPF, because in the patient the EHPVO there will be no ascites, while in the case of Budd-Chiari syndrome there will be a lot of ascites will be there. Okay, so by the clinical features also you can make a that what is the probably etiology in this patient here.
Yes.
Okay. So how you are going to further investigate this patient? What will be your first investigation?
Yes, sir. So I would like to do some investigation to support my diagnosis. So within which I will do radiological investigation and blood investigation. So out of that, I would consider on first radiological investigation. So I would like to do a ultrasound of abdomen and pelvis.
So you don't want to do the upper GI endoscopy for
Yes.
the diagnosis?
Yes. So I would also like to do a upper GI endoscopy after ultrasound of abdomen and pelvis.
So you do a simple ultrasound in this patient suspected to be portal hypertension, or what type of the ultrasound you are going to do in this patient?
So ultrasound of abdomen pelvis with portal venous Doppler.
You do a duplex scan, na?
Yes.
You will do a duplex scan. And what you want to see in the duplex scan?
So the flow of the portal vein, it is hepatopetal flow, hepatofugal.
Whether it's hepatopetal or fugal, yes.
Yes.
Yes. What else you want to see on the color Doppler or duplex scan?
Sir, insist, sir, if there are any collaterals present,
Yes.
yes, sir. Or is there any cavernoma formation
Good.
spotted?
Yes. What you want to see in the liver?
Sir, I would like to see the size of the liver, the echo texture of the liver.
Yes.
Size and echo texture of the liver.
So
Do you
what
look for
happens
any
to the intrahepatic branches of the hepatic veins? What happens? What is the pattern that is called as? Normal pattern is dichotomous branching.
Dichotomous, yes.
Okay. But in the case of the cirrhosis of the liver, what type of the pattern is there? What is that pattern called as?
Sir, I don't know.
Winter tree appearance. Winter tree appearance is there. Okay. In the case of the cirrhosis of the liver. Right. And these branches which are there, they do not reach up to the periphery of the liver. And that is also supportive of the patient is having the cirrhosis liver is there.
Yes.
If you note only one segment of the liver is enlarged,
Yes.
give you any clue?
So I would suspect Budd-Chiari syndrome. So if there is caudate lobe hypertrophy.
Why?
So because the caudate lobe is drains directly into the IVs. So there is relatively hypertrophy of the caudate lobe, and so in case of
Yeah, by a separate vein, isolated vein, it is draining separately. All drains into the hepatic.
yes,
But this have a separate vein, that is why it is. So if you see the hypertrophy of that will be there.
yes.
So what if it is Budd-Chiari syndrome? What type of clinical finding you will have on the chest? Auscultation?
So on the auscultation, I might find venous hum for this.
How it differs from the cannabis sign? The venous hum you are going to get in a crevular Baumgarten sign or the Budd-Chiari syndrome, and how it differs from the splenic vein compression getting a venous hum. Here, this crevular Baumgarten will not have the phasic variation.
Okay.
So venous hum normally will have a phasic variation. If it is a crevular Baumgarten which you see here going to have in the umbilical due to Budd-Chiari, you will not hear the phasic variation. But in a splenic vein thrombosis or the left-sided venous cannabis sign, you will always have a phasic variation on that.
Okay, then what you are going to do after this?
So I would like to do upper GI scopy for this patient. So in which I would like to look for esophageal and gastric varices, and so also changes of portal hypertensive gastropathy in the stomach.
Right. Okay. Then what you do after that?
Sir, if any large varices are present or any kind of bleeding varices are present, I would like to do band ligation or sclerotherapy for this patient, and also start pharmacotherapy.
No, other investigations.
Yes,
What
sir.
other investigations?
Other investigations, sir, if I am suspecting cirrhosis of liver as a etiology of this patient, sir, I would like to do a fibroscan.
Okay.
Sir, other than that, I would like to do blood investigations where, sir, I will do, sir, total complete blood count, sir, and liver function test, and sir, I would like to look for coagulation profile.
Sir, want to ask some question. Jagdish sir want to ask some question.
What are you expecting out of the endoscopy that you are going to ask?
So I am expecting esophageal or gastric varices and the changes of portal hypertension.
Give me the grades of varices when you will be alarmed.
So large, there can, in case of large,
there is no large. There is
nothing called large.
There is complete classification of esophageal gastric varices.
Sir,
Tell me.
Sir, I don't know. Sir.
That's important.
Yeah,
if you don't know, I've got second question for you. When, as a surgeon, will you be alarmed when a endoscopy gives you a report? What is cherry red spots?
Yes, sir. These are stigmata of.
See, this is where the problem occurs. You read theory, you don't know practicals. Go ahead, answer these questions.
So so red color signs and cherry or radial spots. So
Have you seen them ever?
No, sir.
Why? Why? There is no exposure to you.
Yes, upper GI scope is.
Do you have exposure or no?
Yes, sir.
Then why have you not gone there and seen your own patient whom you are presenting to see what are the findings and what is going to happen next day or maybe 15 days later? Give me that answer. Are you sorry for it?
Yes.
Thank you so much. God bless you.
Do you have any idea during the last 5 endoscopy, they have not done a banding or they have not done a sclerosing therapy? You are not aware, no? That is, there is no evidence to say.
Sir, there is documentation, sir, of so banding was done two times.
So what is then definitely, obviously you are having a varices.
Yes.
Then what prevents you to making a diagnosis of portal hypertension? This is the first diagnosis. Why do you want to think all other things?
Yes, sir. Sir.
But you are repeatedly saying no bleeding, no.
So patient didn't have any hematemesis, but they did upper GI scopy.
Done a banding to prevent the hematemesis only. We are doing a banding.
Yes.
What is endoscopic grading of esophageal varices? Do you know?
No, he is not aware. Yes, sir.
According to Sir Babineau's classification, sir, there may be small, medium, or large varices. That is what I know.
Just find out.
Okay.
Proceed.
So what are you going to do for this patient now? You know, your diagnosis in this patient is a patient with portal hypertension, probably of the NCPF variety.
Sir, I would like to so go and I would like to do upper GI scopy for this patient, and if there
That
is
you've done, yeah.
Yes.
You also did the banding also.
Yes. So then I would like to post the patient for splenectomy with splenectomies.
Why you want to do a splenectomy in this patient?
So because first of all, so there is a enlarged spleen.
Yes.
And with associated with hypersplenism.
Yes.
So I want to do a splenectomy, and sir, I want to also the devascularization of the gastrosplenic collaterals.
Why you want to do that? The patient has never bled.
So, but sir, on upper GI scopy, sir, there are varices, esophagogastric varices, so there might be further chances of bleeding.
But you have taken care of that by the banding, isn't it?
Yes.
You have done the banding in this patient.
Yes.
So if you really want to decrease the pressure of that, then you have to go for. If you really want to decrease the portal pressure, what you have to do?
Shunt surgeries.
Sometimes a shunt surgery has to be done.
Yes.
But because this patient has not bled, so many of the people say that you should not go for the shunt surgery because what is the disadvantage of the shunt surgery?
So hepatic encephalopathy.
Yes. So you have to measure the balance between the bleed and the encephalopathy which is there. Okay. So if you have to go for the shunt surgery for the patient having the hypersplenism, what you can do for the not doing the splenectomy, but doing a shunt surgery for the hypersplenism.
Yes. So
which surgery you can carry out?
So distal leonorenal shunt.
Yes.
What is the advantage of this shunt?
So in this shunt, this is a selective shunt where we are not diverting the blood coming from the superior mesenteric vein also. The superior mesenteric vein is draining into the portal vein. We are only diverting the splenic vein.
What is the name of this shunt?
So Warren shunt.
Okay. So tell what are the other selective shunts?
So other selective shunt is Inokuji shunt. where there is a there is shunting between the left gastric vein and inferior vena cava.
Here with that ascites, will you contemplating a distal shunt?
So no, so due to dissection of the left renal vein, so the lymphatics are compromised, and so there can be it can lead to more ascites.
So in your case only we are talking, then you are saying the first thing as a distal shunt. So with the severe ascites, as you said, that is not contemplated.
Yes.
What is intractable ascites? What do you understand by that?
So in intractable ascites is defined as when we are when the patient is on low sodium salt restricted diet, there is and on the highest dose of spironolactone and
How much?
furosemide. So
how much is the
spironolactone
dose?
is 400 mg per day in divided doses, and furosemide is 160 mg per day in divided doses.
With tapping or without tapping?
Sorry, sir.
You tap it or you don't tap it?
So we can try for high volume paracentesis with
You
albumin,
do the
IBM.
tapping, you do all the things, and in spite of that, if it is recurring, then only you call it as intractable.
Yes.
Dr. Dalvi, you want to ask something?
Have you seen a shunt being done?
No, sir.
Have you read about it?
So I've read the types of shunts and cells.
Fair enough. No problem. I just want to ask you because you're talking so much of theory rather than practical aspects. Just one question to you. You are joining the splenic vein to the renal vein. What suture material would you like to use, number one, and the caliber that you would like to use?
So proline 60 or 80.
What is proline?
So it is a non-absorbable monofilament suture.
Why do you use this? I'm going to ask you a question on 60 later. Why proline? If you have used it before, give me an example. I'm telling you one thing. You
Yes,
are well above the people who are answering questions. So you're past and way ahead. But I want to know.
So I have seen using proline 60 or 80 in vascular anastomosis.
Which vascular anastomosis, 60 or 80, you have seen being used?
So in bypass graft, where we use diaphragm graft in bypass for any kind of there is chronic thrombus in an artery, in peripheral arteries we have seen.
So you are working on a peripheral vascular disease, correct?
Yes, yes.
Yes, it's okay. Very nice. I hope your patients are doing well. Now, how does proline go ahead of ethylone in the same situation?
So it is a
Say don't know.
yes, I don't know.
Better. Okay, very fine. You have done a very wonderful job in your presentation, but I think you were very little biased towards what questions were being expected out of you. You should not be there. You should be neutral when you appear for any examination. That much I can tell you. Okay. All the best to you, Das.
Thank you, sir.
Very nice. Very nice. I'm happy.
What are the various ways to anastomose the splenic vein to the renal vein?
So there can be side-to-side anastomosis and end-to-side anastomosis.
No, in relation to the linorenal shunts. What are the various types of the linorenal shunts?
So it can be, sir.
One you just told, which is
Yes.
that?
So Warren shunt, which is distal
Distal
lineal.
one. Okay. Then what are the other ways?
So proximal lineal shunt. So it
Yes.
is also known as Linton shunt. And
Yes.
there is side to side renal shunting.
Yes.
So Mithras shunt.
Yes. Any other way? You can put a PTFE graft.
Yes.
Okay, in between the
Interposition grafts.
yes, you can put that. So there are 4 ways to carry out the linear shunt. So in the selective shunts, you said one is the Warren shunt, second you said the Inokuchi shunt.
Yes.
Any other shunt which is there? The most recent one, which is it's still not recent, it is more than 10 years, but still that is the selective shunt.
Rex shunt.
Surface shunt.
Surface shunt.
What is surface shunt?
So, Rex shunt.
No, Rex is the oldest shunt which is there. It's the using again the 8 mm PTFE graft as a portable shunt. Okay, that is also supposed to be the selective shunt.
Yes.
Right. What are the various types of the mesocaval shunts? Have you heard?
Yes, sir. I don't remember it.
What is TIPS? TIPS?
Yes, sir. It is a transjugular intrahepatic portosystemic shunting. So in this method, we percutaneously from the interjugular IJB, we cannulate. So we reach up to the hepatic vein and we put a needle and cannulate the portal vein, and we put a shunt across it to decrease the portal pressure.
What is the indication for this shunt?
So it can be indication can be failed or refractive. Failed. If we fail upper GI-scopy, if we fail control of bleeding varices by upper GI-scopy 2 times, or so there is refractory variceal bleeding. So there
Or awaiting for the liver
transplants. Yes.
Okay.
So whenever you are planning for transplantation, you will not go for a shunt. You will only think of a TIPS.
TIPS, yes.
Can we stop now? It's
Good. Can I sir? You are there? So thank you, Abhingan. You have done very good. And as Abhay sir has informed, please look into some of the clinical features also.
Yes, thank you.
So definitely you will be able to make great. Because normally in our PG clinic discussions, and if the candidate is doing well, that we will also go to the next level and ask the question, because this is going to be there in the YouTube continuously. Anybody who wants to listen to this class. So all the past 200 classes are YouTubes are available. That is why we are asking some more depth questions. You have done well. Congratulations to you. Keep the tempo.
Thank you, sir.
Nice presentation, Das.
Thank you, sir.
Kanna sir?
Yeah, I think we can close now. Yeah.
Okay. Thank you very much.
Okay, sir.
Good night, sir. Good
For,
night.
Good night, sir.
Good night.
Good night, sir.
So Kanna sir has reached.
Yeah.
Okay. Bye.
Thank you very much, sir. Good night, everyone.
Good night.
Yeah, good night.
Thank you. Good night, sir.
Good
Faculty,
night.
can we
Good
call
night,
a close, sir?
Yeah.
Yes.
Amit sir, Nishikant sir,
And
Kanna sir, thank you very much. Rajesh sir, thank you.
Great appreciation for your perseverance for 200. And we
Sir,
hope-
it is all possible as a teamwork, sir. It is
Yeah.
not a single man show. It is
No,
only
but you-
conceptualized, but later I think most of us are there for except 1 or 2 classes. All the classes have been there. I'm sure all of us have also grown wiser with our classes because we got to exchange ideas with various faculties across the country. And soon we are racing to 5 lakh views on the student side. So I wish that landmark is also broken quite fast. And next week we are having a cervical rib. Some students wanted to discuss that thoracic steel syndrome. So that case is ready, and I'm looking out for one arterial case. So we'll have a vascular session next week. That is the plan, sir.
Good. Thank you.
Thank you very much, sir. Thank you.
Thank
Good
you.
night, everyone.
Okay,
Good night.
sir.
Good night. Good night.
Good night.
Good night.
Good night.
Good night.
Good night, sir.
Thank you, sir. Thank you.
Thank you, sir. Thank you.